Hello, my name is Rachel Jones. I'm a certified industrial hygienist and professor at the University of California, Los Angeles, Fielding School of Public Health. Welcome to Selecting Appropriate Occupational Exposure Limits. In this module, we'll discuss the types of occupational exposure limits, or OELs, and the organizations that set them. The module learning objectives are to differentiate among the various types of occupational exposure limits, to identify the predominant authoritative organizations that set occupational exposure limits, and to align occupational exposure limits and occupational exposure scenarios. The module learning objectives are to differentiate among the various types of occupational exposure limits, to identify the predominant authoritative organizations that set occupational exposure limits, and to align occupational exposure limits and occupational exposure scenarios. Organizations that establish OELs. In the United States, we typically look to three organizations for occupational exposure limits. First is the Occupational Safety and Health Administration, also known as OSHA, which sets occupational exposure limits that are regulations. Employers are required by law to comply with occupational exposure limits set by OSHA. States that have state-managed OSHA programs may also set occupational exposure limits that are regulations used in that state alone. State-based regulations must be at least as protective as the regulations set by federal OSHA. The American Conference of Governmental Industrial Hygienists, also known as the ACGIH, sets recommended occupational exposure limits, and these limits are used globally in industrial hygiene practice and in some places are adopted as regulations. The National Institute for Occupational Safety and Health, also known as NIEHS, sets recommended occupational exposure limits. Often NIEHS makes recommendations in anticipation of regulatory actions that are being considered by OSHA. In Europe, the European Chemicals Agency, known as ECHA, sets OELs based on the authority provided in the Chemical Agents Directive 98/24/EC, the Carcinogens and Mutagens Directive 2004/37/EC, and other directives. Several federal governments within the European Union also set occupational exposure limits. Industrial hygienists in the United States are typically most familiar with those set by the German Senate Commission for the Investigation of Health Hazards on Chemical Compounds in the Work Area, better known as the MAK Commission. In addition, companies may set OELs that are followed within their organization. Sometimes these are referred to as internal OELs to denote that they are used inside a specific company. Some organizations publish these OELs in their safety data sheets. For example, Dow sets industrial hygiene guidelines for use by their company and includes them in safety data sheets for Dow products. It is important to note that the settings of occupational exposure limits by organizations is not always based solely on health concerns. In particular, OSHA is required by law to consider the technological feasibility of employers to limit exposures and the economic feasibility of implementing the necessary controls. Such constraints are not imposed upon OELs set by ACGIH and NIEHS. It is also important to recognize that OELs are set by individuals using the available information at the time. Individuals involved with setting OELs in these organizations are highly skilled in the disciplines and value the protection of workers' health and safety. Nonetheless, as in any human endeavor, they bring to bear their personal values and social norms on the setting of OELs. The available information used to set OELs may have gaps or deficiencies which can introduce uncertainties. New data generated in the future may demonstrate that an OEL set 10 or 20 years in the past was not adequate to prevent ill health among workers. Thus, it should be appreciated that OELs represent the best understanding of the evidence base at the time they were set, but may be insufficient to protect all workers from harm. There are several types of OELs that specify the amount of a chemical in the breathing zone of workers, which vary with duration of exposure. These include 8-hour time-weighted averages, 15-minute time-weighted averages, and 5-minute time-weighted averages, or peak values. The duration reflects the time scale over which the adverse effect is expected to occur. Short time scales of 15 minutes or less are used for OELs when the health effect is acute, such as loss of consciousness or irritation. The 8-hour time-weighted average is used for agents where the effect is associated with repeated exposures over time. One chemical may have OELs specified for multiple durations for different health effects. When this occurs, the OEL assigned for the shorter exposure duration is typically a higher airborne concentration than the OEL assigned for the longer exposure duration. For example, for acetone, the short-term exposure limit over 15 minutes is 500 ppm, while the exposure limit for an 8-hour time-weighted average is 250 parts per million. It is common to make the exposure duration explicit when referring to an OEL to ensure that it is correctly understood. For example, we would say that the OEL for acetone is 250 parts per million as an 8-hour time-weighted average. While most organizations develop OELs that correspond to the 3 exposure durations we discussed, they may give them different names. OELs set by OSHA are termed permissible exposure limits, or PELs, and may be 8-hour time-weighted averages, short-term exposure limits, denoted STELs, S-T-E-L, or ceiling limits. Some OSHA regulations have a special type of limit called an action limit, which is equal to 1/2 of the 8-hour time-weighted average permissible exposure limit and triggers specific occupational health and safety program activities. For example, the benzene standard includes an action limit as well as a permissible exposure limit. OELs set by the ACGIH for airborne chemicals are termed threshold limit values, or TLVs, and these may be of any duration. OELs set by NIEHS are termed recommended exposure limits and also may be of any duration. OELs set by NIEHS are termed recommended exposure limits and also may be of any duration. An example of a biological exposure limit in urine is 2 milligrams of methyl ethyl ketone in urine, measured at the end of the shift. Sometimes it is a metabolite, not the original chemical, that's measured in urine, and it may be normalized to the level of creatinine in the urine. Creatinine occurs naturally in the urine. Normalizing the chemical or metabolite to creatinine is done to control for the urine flow rate. An example is the biological exposure index for 2-butoxyethanol, which is 200 milligrams of butoxyacetic acid per gram of creatinine in urine, measured at the end of the shift. Some biological exposure limits are set for blood, and an example is lead. The OSHA standard for lead in the construction industry requires that workers with blood lead levels of 500 micrograms per deciliter or more be removed from work, and workers with blood lead levels of 40 micrograms per deciliter or above be provided more frequent medical surveillance. Because chemicals are metabolized and excreted from the body, biological exposure limits must be used with consideration for the timing of this process, which varies among chemicals and can range from hours to months. If you wait too long after the exposure has occurred, the chemical may no longer be detected in the body tissue or body fluid. Dermal exposure involves chemicals coming into contact with the skin, whether the chemical is in bulk form or on a surface or in the air, and the uptake of the chemical into the body through the skin. While the amount of a chemical on the skin can be directly measured, there is not consensus about dermal exposure assessment methods. As a result, biological OELs can be used to evaluate exposure through the dermal route. For airborne chemicals, the potential for dermal exposure is generally accounted for in the setting of the OEL for the airborne chemical concentration. Even without a dermal OEL, directly measuring the chemical on the skin may still provide useful information about the need for or performance of personal protective equipment or other exposure controls, and to monitor whether the exposure changes over time. In recent years, there's been an interest in developing surface occupational exposure limits to describe the maximum amount of a chemical that can be present on a surface. One of the drivers of surface OELs are concerns about dermal exposures to pharmaceuticals, including hazardous drugs like anti-neoplastics, and also concern about chemicals that can cause skin sensitization. Surface OELs can be used to monitor housekeeping in the workplace, as well as to help decrease workers' exposures. Surface OELs have units of chemical mass per surface area sampled, such as milligrams per square centimeter. OSHA has not set surface OELs to date, but they are being developed by ACGIH. Bruce Nauman and Susan Arnold have proposed a strategy to develop surface OELs for chemicals that cause skin sensitization. The basis for the OEL is the results of the murine lymph node assay, denoted LLNA. The LLNA is an in vivo toxicological test that is used to identify chemicals that have the potential to cause skin sensitization. EC3 is the effective concentration value determined through the test, where lower values reflect chemicals with more potency for skin sensitization. The first equation converts the toxicological test parameters into the LLNA EC3 value with units micrograms per square centimeter. The numerator is the chemical concentration in the vehicle that, when applied at a certain volume over a certain area of the mouse ears, produces the criterion stimulation index result in the mice. The second equation converts the LLNA EC3 value into the surface OEL using a composite adjustment factor, which could also be described as an uncertainty factor. Newman and Arnold suggested that a banding approach be used to define surface OELs based on the LLNA EC3 value. Banding approaches are used in industrial hygiene to set OELs without a formal risk assessment. Notice in the table that the surface limits shown in column 3 are ranges, not exact numbers like many OELs. Again, the basis for the OELs is the LLNA EC3 result, classified into categories based on the chemical potency as a skin sensitizer. Notations are used to provide additional information to the industrial hygienist to assist with risk assessment and management. Some notations include carcinogenicity. Carcinogenicity classifications are made by authoritative organizations after review of the available information and are based on the strength of evidence. Different organizations have slightly different criteria for classification, but generally reflect whether a chemical is a known, probable, or suspected carcinogen. Skin notations are used to emphasize the importance of dermal exposure for a chemical, but different organizations that set OELs use different criteria to assign the skin notation. Generally, the skin notation implies that either skin contact can cause irritation or that dermal absorption can be an important route of exposure and should be prevented. An ototoxic chemical can cause hearing impairment by traveling through the blood to the inner ear, damaging parts of the inner ear and neural pathways. An ototoxicity notation is used to indicate that particular attention should be paid to noise exposure and monitors workers' hearing loss. The sensitization notation is used to alert the industrial hygienist of the need to pay particular attention to limiting exposure so as to prevent workers from developing sensitization. Sensitization is a critical health outcome because it can be a long-time condition that puts workers at risk for severe reactions to subsequent exposures, even when those exposures are to very low levels of the chemical.
This lesson has been created by the Interdisciplinary Training, Education, and Research Activities for Assessing and Controlling Contaminants from Emerging Technologies Program, a collaboration of the University of Minnesota School of Public Health, the University of Iowa College of Public Health, and the University of California, Los Angeles Fielding School of Public Health. Funding for InTERACCT is provided by the National Institute of Environmental Health Sciences of the National Institutes of Health. The content of this lesson is the sole responsibility of the developers and does not necessarily represent the official views of the National Institutes of Health.